Good afternoon, everyone. My name's Associate Professor Libby Callaway, and I'm the Independent Living Stream Lead in the Rehabilitation, Ageing and Independent Living Research Centre at Monash University. I'd like to begin this afternoon's satellite session by acknowledging the traditional owners of the various lands across which we meet today in this online event. I'm talking to you from the lands of the Boonwurrung people, and I pay respect to elders past, present and emerging, and any Aboriginal or Torres Strait Islander people who may be joining us today. We've got a fantastic session this afternoon in this Carer Knowledge Exchange Research Incubator. I just wanted to start with a little bit of housekeeping for you. I would like to note that this session is being recorded purely for a visual narrative that will be produced out of the session. So if you do want to raise a question, we'll only be using first names so we can keep your personal information private. I also wanted to really tell you a little bit about this great Carer Knowledge Exchange. Some of you might have been in the previous session coming out of New South Wales before this session that started today, but I'm just going to take you through a little bit about the session, about the knowledge exchange and the session itself. The Rehabilitation, Ageing and Independent Living Research Centre is really pleased to be hosting this session as a satellite event of the Carer Knowledge Exchange Research Incubator in 2023. And this has been running from Tuesday to Thursday this week, so there's still more sessions to come, which I'm going to tell you about in just a minute. But I'll just take you through a little bit more about the Carer Knowledge Exchange itself. This exchange has been delivered for a number of years now by Carers New South Wales and the Institute for Public Policy and Governance at the University of Technology, Sydney. And it's proudly funded by the New South Wales Government. It aims to improve outcomes for carers by connecting research to practice. And the session I've just been in with others this afternoon was chaired by someone with lived experience as a carer, both within the NDIS and also the aged care systems in Australia. It brings together carers, researchers, students, decision makers, professionals and service providers to share their knowledge about carers and learn from each other. The website has a rich amount of information on it, and the URL link is listed on screen there, www.carersknowledgeexchange.com.au. The features on there include a searchable library of research and best practice publications, information on regular events and webinars being run, and opportunities for you to connect with others interested in this area of carer knowledge exchange. There are some more sessions in this week of very busy events, as mentioned. Tomorrow, there's a spotlight series from 12 till 12:30 p.m. AST, and there's also a workshop on measuring carer wellbeing in research and practice from 2 p.m. till 4 p.m. All sessions are being recorded and they can be shared for on-demand viewing following the event, but there is a QR code on screen if you need any further information about those events coming up. We've got a fantastic session this afternoon. This satellite event is really focused on understanding hidden carers and carer diversity. And we have 5 very experienced presenters from various organisations, as you can see on screen. We have Tamara Pearce from Carers Victoria, Dr. Aslan Laylor from the Rail Research Centre at Monash University, Associate Professor Tanya King from the University of Melbourne, Dr. So Sin Sim from Monash University's Occupational Therapy Department, and Professor Anne-Marie Hill from the University of Western Australia. So I'm now going to invite our first speaker to start sharing their screen, and I'm going to introduce them firstly on screen. Tamara Pearce is the statewide sector development manager at Carers Victoria, and she's going to be presenting to us this afternoon on carers and service navigation. Thank you, Tamara.
Thanks, Libby. Hopefully everyone can see and hear me correctly. Fantastic.
Very well.
It's an absolute pleasure to be here today. My name's Tamara. I'm from Carers Victoria. I'm the manager of the statewide sector development. And I'm here to talk about carers, obviously, and to talk a little bit about Carers Victoria. A lot of the presenters here today coming from a research background, and I'm going to be talking about what we've learned from our services and from our work at Carers Victoria. I'd like to start first by acknowledging the lands that we're all coming from today. I'm here today from Wurundjeri country, from the Kulin Nation, and I'd like to pay my respects to elders past, present and emerging. Carers Victoria is 30 years young. Our vision is that all unpaid carers are recognised, valued and supported, and that underpins all of the work that we do. I'm very proud to say that we have more than 50% of the staff that work at Carers Victoria identify as a carer themselves. And I think that's a really important point, because a lot of the work that we do brings a lived experience of the people that work there. And it really makes us a stronger organisation. So we'll talk a little bit about what Carers Victoria does, and I'm also then going to talk about the barriers that carers experience as they're trying to navigate systems and services. And this is one of the biggest issues that we see in the work that we do, that carers just not getting the services they need because they have such difficulty either finding the service or navigating the service and how to use it once they get there. So we are the peak body and we represent carers, an advocacy and information service. We have an interest in policy, obviously, and research. We also provide direct services to carers, respite, counselling, and importantly, we have a telephone advisory service that is very well utilised here in Victoria and is statewide. Other sorts of things that we have are events, a whole range of different projects, different programs. And in the area that I specifically work in, sector development, we work really closely with other organisations such as councils and neighbourhood houses to assist them to make their services carer friendly and to be inclusive of carers and to understand the experience of carers so that they can access those services. So we work across the three sort of domains. And the conversation or the comments that I'm going to make today are all about us learning about carers and what we've learned from talking to the carers that we work with. A little bit about Victorian carers. I know people might be coming from different states. This is probably not dissimilar to what happens in other states, but I think it's just really important to keep in mind that predominantly a little bit more than half of carers are women, and carers are twice as likely to have a disability than non-carers. And this is a really significant thing when we're considering people navigating different systems. Now, I want to talk about system navigation in terms of two very specific different systems. And the reason is they're perceived very differently from carers. So there's the obvious systems that carers experience and navigate, and the four big ones that mostly we support people to navigate are obviously the NDIS, My Aged Care, or the health aged care service in general, the mental health system. And here in Victoria, that's really significant. We're undergoing quite a lot of reforms. There's quite a lot of changes to the mental health system. There's some fantastic recommendations that are being implemented from the Royal Commission, but that's also then brings with it a lot of change for carers to navigate as well. And Centrelink through Services Australia is a really significant system that carers navigate with. The NDIS, also a late colleague of mine always described it as the NDIS is not black and white, it's purple. And I think that's a really good description of the NDIS, and that it's very difficult. Once you sort of navigate it and understand it, then a whole raft of changes come through. So I think the theme with all these systems is they're very separate. They don't talk to each other, and they change and evolve over time. So there's a lot of pressure on carers to keep up to date with services and systems. The carer-specific support systems, such as the Carer Gateway, the federal and the state systems, that are specifically for carers have other different types of barriers, specifically around knowing that they exist in the first place. We have so many carers come to us and are not aware of different services that they can access. Predominantly that's because often people don't even themselves identify as a carer. So it can be very difficult for that process to happen and then to start looking for services or things that might assist them. So a couple of really important facts that we need to keep in mind when thinking how can we support people navigate these services. Often carers themselves are at a much higher risk of having an illness or a disability. And I think it's a really important point to keep in mind that often carers are not carers in isolation. They're often someone who requires care themselves. They may be aging, they may have a disability themselves, and that people move between the carer role and being or requiring some sort of service or care for themselves. Often our carers put the needs of the person they're caring for first, and therefore they put their own health and well-being secondary to that. And that's where we see people might spend their time and energy accessing the direct care services, such as my aged care, but then not feel that they have the time or energy to access something that might be available for them through their state-based carer services. Another really significant point to understand around navigating the systems is that a lot of carers have difficulty with employment. They are less employed than a non-caring person would be, and it takes a lot of time to navigate the systems. Often we think that carers spend a lot of time in their caring duties, and they do. They spend time transporting or taking physical care of people, but there's also the burden of time that takes for people to navigate services. It can take quite a lot of time to follow application processes, calling Centrelink sometimes, for example, people might be on hold for an hour. By the time the call's picked up, what's happening in the household has drastically changed. They've got the baby's woken up, or they're in the car now and they can't access the paperwork that they need. So it's these sorts of everyday stresses that really make it difficult for people to connect with the services, and then once they get there, have the time and be able to spend the time in order to get the processes through and to get the services that they need. So there is a bit of a theme in everything I've said. I mean, you've probably picked it up, but it is about time. And carers are always telling us that time is of the essence, and that is what they have the least of. It is the most precious resource for them because they are so very busy with their caring duties, with the system navigation, and with all of the other responsibilities that they have. In terms of accessing support, we have seen low utilisation of the Carer Gateway, which is the main system for carers to get some support. It is intended to be the main entry point, and the 2022 Carer Survey found that only 36% of the respondents had used the website and fewer than 30% had called Carer Gateway. So it shows us that it's difficult, or that people they don't know about the service, or they don't have the time, I would imagine, to use the service. And a lot of people found or experienced the application process is a real barrier to accessing services. So system navigation is continually coming up for us as an issue for carers. It's what they talk about the most and often needing the most support with. We have a telephone advisory service that's available to anyone statewide. And I think it's a really interesting point that 50% of our callers choose to remain anonymous. And I think that there's probably a lot of reasons for that. And we're very happy to assist people, even though they don't need to tell us who they are. I think undoubtedly one of the reasons for that is that people don't want to give their information again. They don't have the time to repeat that information, or they have a fatigue around always continually giving information. And also that our service is about short, sharp information and support to what the person needs at that moment in time. So in terms of the barriers to system navigation, these are the things that we've collected through the phone service, through the research that we do, through the consultation with carers that we have, and obviously internally with our staff that are supporting people through systems as well. One of the biggest issues is, as I mentioned, the big four systems. They're very disjointed. They don't talk to each other. So there is always this multiple telling of people's story of, in some cases, that can be traumatic. It's certainly tiring for people, and that there is information that's hosted on multiple systems so that when information changes, like someone moving house, there is a whole host of people that they need to then convey that information to or rediscover services in a different area. Technology might be the answer to that. If we could get all the back-end systems to talk to each other, that would be great. But technology, and I think that's a long way down the track, but technology is also the biggest barrier for people. And some of the earlier presenters today, which were fabulous, touched on these issues as well, that it's not just about the digital literacy or language literacy. It's about understanding those terms in that context, understanding that specific system, the way the NDIS talks about certain phrases or certain concepts is different from how aged care talks about similar sort of systems. So that can be really difficult for people that they may even have English as a first language, but understanding in that context and having that, excuse me, digital literacy for that system as well is an overwhelming issue for people. Carers who care for multiple people also talk a lot about the difficulty and the complexity that brings. For example, a parent who may have 2 children with a disability, they would need to interact with the NDIS twice in an individual sort of process for both of those children. And it just brings a much greater level of complexity for people. And another significant factor is that people talk about often support, phone support, or coming in face-to-face, that kind of support is only available during business hours, which makes it really difficult for carers who may be very busy during the day caring for family, have employment, and getting home at night and 8 o'clock or 9 o'clock at night is the first chance they've got to sit down and really think about what they need to do. So that keeps coming up a lot for people as well. We had, I've touched briefly on the hidden carer. I think this is a really significant issue, and there's something about us as a community that we need to talk about caring and caring responsibilities so that people understand and identify as a carer. And often we find that people don't necessarily come to that conclusion till they've been in a caring role for quite some time, or they realise they're a carer after something quite traumatic has happened. Someone's had a significant illness and suddenly they're in that role and it's very new to them. So that's definitely an area of helping and supporting people really recognise that there are services there that can support them or help them with their caring role. And the other group that is really has additional difficulties is culturally and linguistically diverse people. People who have come from overseas may not understand our social or support structures. So there's that barrier as well, in addition to the language barrier. And also some people may not be literate in their own language. So therefore, coming here and being provided with an interpreter, either on the phone, face-to-face, which is fantastic. And pleasing to see that there is a lot more language services, and since COVID there's a lot more information translated as well, but it may still not be accessible because it's not contextualized to that individual's particular situation or to their particular understanding of what this information needs. So that's something that is really significant and really helped by having bilingual and bicultural workers who understand the system as well. An interpreter is only really able to facilitate between 2 people, but having the knowledge of the language and the systems together is really helpful to really work with the person to understand where they're at and what their needs are. And the other difficulty or pain point for carers that we find is moving between the different systems often happens in a time of crisis. And what are the additional supports that people need to navigate those systems when they're dealing with a really unwell family member who may have a disability, or having to access an additional system when they're already in a very stressed and heightened kind of state of mind. So there's sort of some of the significant barriers that carers are telling us that are their frustration points and where they need assistance with. And certainly we don't have all the answers. I wish that we did, but there are a lot of really good projects. There are a lot of good research. There's a lot of good single point projects that might help someone with a disability or someone in aged care. But that overall point of bringing it all together is really hard to coordinate that care. So in terms of what the solutions are, it will be different for everyone. And certainly the list that I have here are just really superficial thinking about how can we try and, keep in mind all of the uniqueness of a carer and their own particular family situation. I think that there's a lot more focus on co-design, which is fantastic, and it's really essential to have the carer involved in systems design if possible. And I would say to people, employ a carer. If you're a service provider, a university researcher, there is no greater way to get great carer insight than to actually have them working with you and alongside you.
That's such a great point. Thank you.
Yeah, sorry, I've gone over time. That's actually my last slide. So thanks, Libby.
No worries. I just think that's a great note to really be highlighting. We actually have two consumer representatives on the Rail Research Centre advisory, and the expertise they bring in that area is invaluable. We are inviting questions through the chat, and we're also inviting them through the Q&A button. We've got a lot of time at the end for questions, so that's fantastic. But thank you, Tamara, for that detailed tour, and thank you to Carers Victoria for the ongoing work that you do, because I've used your service both as an occupational therapist and also as a family carer, so thank you very much. All right. Thank you, Tamara. I'm going to ask you to stop sharing, and I'm going to ask our next speaker to now begin sharing their screen. Our next speaker today is Dr. Aslan Laylor. Aslan's a senior lecturer in the Department of Occupational Therapy and a senior research fellow in the Rail Research Centre at Monash University. Her presentation is titled "Some Days Are Diamonds, Some Days Are Rocks: Older Carers' Narratives to Inform a Carers Clinic." Thank you, Aslan.
Hello, and thank you all for attending today. As Libby mentioned, my name is Aslan, and I'm a Senior Research Fellow in the Rehabilitation, Ageing and Independent Living Rail Research Centre at Monash University, and also a Senior Lecturer in the Department of Occupational Therapy. So my presentation today is going to provide a brief introduction to the Rail Research Centre and an overview of the Carers Narratives project our team has undertaken over the past year or so, as well as some of the next steps. So as a little background for those who aren't aware of the Rehabilitation, Ageing and Independent Living Research Centre, fondly referred to as RAIL, we're based at the Peninsula campus in Frankston of Monash University here in Victoria. RAIL, as its name suggests, is an interconnection between rehabilitation, ageing and independent living, and the centre is dedicated to improving how people live, including carers and their care recipients, with greater independence and quality of life. A number of the research team at RAIL were part of a project team looking at who cares for the carer. And this was led by Professor Keith Hill, who is the director of RAIL and is pictured standing on the left on the slide. Keith also presented aspects of this broader project yesterday on Tuesday as part of the CKE Research Incubator. So if you missed it, you might be able to review the recording of that session later also. So the project overall is in 3 parts, one of which I will focus on more today regarding the carers' narratives. However, it's also included an initial survey of older carers Australia-wide, and then a subsequent co-design workshop panels following the interviews. As some background to the project conception, the team reviewed the evidence, particularly in relation to carers, and 2 key reasons, particularly that Tamara was touching on earlier, are that they have high levels of unmet needs and difficulties navigating the complex systems. And obviously this is something that carers have reported for some time. We further focused on older carers, and by this we mean carers who are aged 50 years and over, who are caring for someone 65 years and older. And our reasoning for this focus was for a number of reasons, again, similar to what Tamara was touching on earlier. Often older carers have moderate health problems of their own and difficulties juggling that carer commitment with managing their own health and wellbeing. Often also the person that they're caring for is a spouse, and with that person being older, they tend to have complex health needs and problems that have been shown to add to carer stress. and obviously higher levels of care needed because of that care recipient being older. There is limited research on older carers and less on older carers of older people, and therefore was another focus for us to be looking at this area. Caring for an older person in declining health can bring satisfaction and personal growth for the care partner. However, over time, the demands of caring can negatively impact the care partner's well-being and ultimately the sustainability of that caring role. So older care partners who often have their own health conditions and limited ability to focus on their own health may be at a particular risk of poorer health outcomes. And therefore, we aimed in the phase 2 of our project was to explore the lived experience of older care partners or carers of older people to inform development of a novel service to support care partners' health and wellbeing. So we conducted semi-structured interviews as part of a qualitative study, and these were conducted over the phone or online via Zoom with older care partners in either Victoria and Western Australia. And this was with older carers who were providing care to an older person. And by that, as I was saying before, so the carer needs to be over 50 and the person they were caring for being over 65. The interviews were recorded, transcribed, and then analysed using a method called thematic analysis. And this is a method that's used for exploring and interpreting the meaning across the data that it's collected. We had 14 carers participate with an average age of 71 years. Predominantly, most were female, and nearly 2/3 were caring for their spouse or partner. The average age of care recipients was 78 years, and as you can see, the main diagnosis of the person being cared for was dementia in this study. We identified 4 themes that described the care partners' experiences, and these related to the impact of caregiving, the barriers and facilitators to caregiving, the coping strategies they identified, and their preferred support. So all carers highlighted various impacts the role of caregiving had on them. And one carer stated, "Some days are diamonds, some days are rocks." And this appeared to really reflect the various impacts carers were experiencing. As you can see on the slide, there were some real key impacts that were reiterated by many carers and that it had been life-changing. So the emotions, the strain, the guilt, anger, feelings of being robbed, but also loss. So the loss of the person that they had known or loss of their own identity, loss of social connection, as well as the impact on their time for all the additional roles that they had to take on. And again, like Tamara was talking about, that time factor really came in because they just don't have enough time. There's just so many things that they having to do in order to be able to care for that person and maintain their household. A number of carers spoke also about being robbed, as I mentioned, but it was not just for themselves, but feeling that their loved one was robbed as well. Carers also highlighted multiple barriers to their caregiving, and carers felt they were amateurs and not prepared in a number of ways. So supports, information, and lack of knowledge were key factors, and this could relate to the care recipient's condition, what to expect, but also knowledge about where to go, what to access, and not knowing what to ask for. Additional factors relating to the care recipient included symptoms of their condition, and resistance to care by that care recipient. So the person may be resistant to losing their independence and not wanting anyone to come into the home to help. And this obviously had an impact on the carers not having additional support to be able to support them to do the job of caring for the person. Carers were also concerned about their finances currently and how this would play out in the future, as well as concerns about alternatives for their loved one if they were not able to continue to provide care. Despite multiple barriers, carers did also acknowledge a number of facilitators, and you can see these on the screen. These predominantly focused on access to appropriately trained as well as the right support workers for their loved one. So, for instance, someone with knowledge and expertise of working with someone with Parkinson's disease. Also access to support, so including family and friends, but also formal support services, peer supports, so others who were going through it or had been through a similar situation, having a good relationship with their GP. And they also reported that these supports were really helpful if they were flexible. So about the timing, again, like Tamara had mentioned, not just during business hours, but also via phone, so it didn't have to be in person necessarily. And also that there was a consistency with the person, so they're not having to repeat their story every time. It was also about being supported in able to navigate the various systems that they were having to engage with, so aged care, health systems, Centrelink, and so on. Carers also highlighted being provided written information, particularly early on in their carer trajectory, were really beneficial. All carers spoke about strategies they employed to help manage their caring role. Carers talked about coming to terms with what was happening and accepting where they were at in the present moment were really helpful. A number of spoke about taking one day at a time, putting things into perspective and remaining positive about them doing the best they could with where they were at. Additional strategies involved reaching out to their GP, as we were talking before, being able to vent to family and friends, and also participating in exercise when possible. Lastly, carers talked about the preferred supports to aid them in their caring role. Many spoke of the need to have a good relationship with their GP, as well as having access to peer support, so support groups, counselling support and psychological support. And the counselling support linked to, sometimes family dynamics and social connections, or helping deal with the guilt of, that they were feeling in relation to their caring role. Also giving them opportunity to build confidence and be more positive, and how to manage the additional load. But a lot of the psychological support related to more about that anticipatory grief, the loss of the relationship that they had, and what they had expected to have had with their loved one, and recognition and allowance for assistance and support. So getting some of that coping strategies. Consistency in people providing respite was really key. So particularly for those coming into the home, to ensure that there was a relationship that was developed and facilitated with the care recipient. And then that person's more likely and willing to accept that respite care in the future. Recognition of the work that the carer does and their expertise that they bring, as well as providing the carer some choice and control over the supports that were being implemented. It was evident that older care partners can assume the caregiving role because it naturally falls to them as a family member, or there seems no alternative, while also feeling neither recognised nor valued for the essential role they fulfil. And the voices of these older carer partners that we've just talked through today have helped to inform a new model of carer support. And this was developed through those 3 co-designed workshops held with carers and health professionals and key stakeholders. And this has now received research funding for implementation and evaluation. So where to next? We're currently in the phase of implementing this pilot of the co-designed novel service to meet the unmet needs of older carers and older people. And it's going to be a carers health and wellbeing clinic, which was what the carers identified as a good name to what they would link with. So not just being a carer clinic, but focusing on that health and wellbeing. So the clinic is in development, as I was saying. It's going to be established in Frankston with support from Peninsula Health, and it'll be run on a Friday initially, and working towards opening it more than once a week. And we'll have social work, psychology, physiotherapy and occupational therapy disciplines in that practice. And we're hoping for it to commence in July, August this year, if everything remains on track. So I thank you very much for your time today. If you'd like to know more about this project or to keep in touch about others as well at RAIL, please either visit our website, which is listed on the screen there, or if you'd like to subscribe to the RAIL Research Centre, please email the email that you can see on the screen as well. Thank you very much for your time.
Thank you for your time. I'm going to invite our next speaker, Associate Professor Tanya King, to now begin sharing her screen. Associate Professor King is from the Australian Research Council, she's an Australian Research Council DECRA Fellowship. She's from Melbourne University, and she's also the Dame Kate Campbell Principal Research Fellow at the university. Welcome, Tanya.
Hi, everybody. It's a pleasure to be here today. My name's Tanya King. I'm a researcher at the Melbourne School of Population and Global Health at the University of Melbourne. I'd like to also acknowledge the traditional custodians of the lands that I'm working on today, the lands of the Wurundjeri people of the Kulin Nation, and pay my respects to elders past and present, as well as any First Nations people that are here today. So, This is the path I'm going to be weaving for you over the next 10 minutes. Firstly, I will just be defining young carers. Then I'll be contextualising that in the period of adolescence. We'll talk about why that matters. And then I'll just briefly draw on some work that my group has been advancing, looking at the mental health impacts of caring as well as suicidal behaviours. And then finally, some implications and final comments. So briefly, we define young carers as adolescents and children who provide informal unpaid care and support to someone else, typically a family member with a disability, physical or mental illness, a substance dependency, or who's elderly. And the range of tasks that young carers can engage in can really vary, and it can also vary in terms of intensity as well. Now, the impacts of, there can be many, many impacts of caring across a range of different domains that you can see there. And when we think about these impacts, it's also important to think about when this is occurring, the period of adolescence. Now, society places a great deal of emphasis on the first 10 years of life. This is an incredibly important life period, and what happens then can really shape life outcomes. But there is growing recognition that what happens in the second decade of life, the period that sort of roughly translates as the period of adolescence, is also of really vital importance. And the changes that we see there are really immense. We often recognise the physical development that occurs at this time, during this time, but there are a range of other massive changes as well. And you can see there's significant shifts in cognitive development. We see massive changes in neural connectivity and myelination. We see massive changes in terms of social development, where as parents, our influence and importance declines, and we see this growing importance of peer relationships. We also see shifts in emotional development. The period of adolescence is sort of this period of intense self-involvement, and there's worries about being normal and fitting in. Now, for young carers, the latter two developmental domains really place them as being quite different to their peers. While many of them may be motivated to be seeking and making new friends, many have less time to do that because they're much more focused on caring for somebody else. Their worries as well, in addition to the normal worries, they have additional worries about, particularly about the person that they're caring for. So if we go back to this slide on impacts, it really makes sense that young caring could have a significant impact on mental health, because their caring role can really be at odds with what's going on for them in terms of developmental trajectories. Now, it's important to recognise that optimising health and wellbeing in adolescence is vitally important, because it's really setting the foundation for future adult health and wellbeing. It's also the period when mental health symptoms first emerge, or often first emerge. And we know that the mental health in adolescence is highly associated with adult mental health. So any impacts that we're observing in this period will potentially have implications for adult health and wellbeing. So in terms of evidence gaps, we have good evidence of mental health impacts of caring based on adult samples, and some really rich qualitative work has described the mental health of young carers. But there's been a real lack of comparative research, and by this I mean that there was a real need for research that demonstrated that the mental health of young carers might be different to that of non-caring peers. So using a comparator, and B, longitudinal evidence. And this sort of evidence was really needed to demonstrate causality. So that is that caring might be causing poor mental health in young carers. And this has been a real focus of my group. And I'll note, just picking up on one of Tamara's points, that we have employed a young carer, and she's really been a terrific addition to our team in terms of advancing the research focus. Briefly, the methods that we used in the studies that I'm going to be talking about today used the longitudinal or data from the longitudinal study of Australian children, LSAC, that, as many of you will know, is a large cohort study, has been in the field since 2004, among, I think, roughly 10,000 children, 5,000 in the sort of cohort that I'm going to be talking about today, and has been measured, or data has been collected every 2 years. So first of all, just be talking about some work that we, in which we evaluated the mental health of young carers. We compared non-carers, daily carers, and then those who were also carrying out care but less than daily. And we used a method called augmented inverse probability weighting, which is just something that really tries to mimic a randomized control trial, and really enable us to causally assess the effect of caring. So we assessed caring at the age of 14 or 15 years, and then compared the mental health of these 3 different groups 4 years later when they were 18 to 19 years, adjusting for lots of other variables as well that might be having an effect. And this was really trying to step out the causal ordering of these different variables. We found a clear effect of caring at the age of 14 to 15 years on mental health 4 years later. And this was particularly pronounced among the daily caring, so those who were providing probably the more intensive sort of caring daily. Next, we have looked at, and this is sort of hot off the press analysis, we've looked at associations between caring and self-harming and suicidal behaviours. And we assess caring as core, looking at core carers. So this is people who were performing probably more intensive caring, caring for assisting people in terms of communication, moving around, and also physical, so or some of the more personal care, so often intimate caring. And we compared those who were providing core care and those who were not providing core care, and looked at their a range of different suicidal and self-harming behaviours and outcomes 2 years later. Now, we found when we looked at thoughts, so this is thoughts of self-harm, thoughts of suicide, making a suicide plan, there was no difference between carers or those providing core care and those who weren't providing core care. But concerningly, those providing core care were more likely to have self-harmed or attempted suicide in the previous 12 months. So, and the estimates, it was about twice as many. So it's almost doubling those sorts of behaviours. And we attested that association in a range of different ways. We looked at any caring versus no caring. We used complete case versus imputed data, and the results were robust. So flicking back to the earlier slide, this is really concerning because we know that this period of adolescence is really of paramount importance in setting the foundations for young people's future health and well-being. And any inequities that we observe in this period will potentially carry across the life course. So in closing, we can say that we have increasing evidence of the causal impact of caring on mental health and suicidal outcomes of young carers. And really there's a need to be supporting young carers to try and mitigate these potential impacts. And finally, to do this, we really need to know how best to help and support young carers to mitigate these effects. And picking up on some of the other comments so far, we need to identify how best to identify carers, or particularly young carers in this case, and how to link young carers to services. And that concludes my presentation for today. Thank you all for your attention, and I'd love to hear from anyone who is interested in this or has any thoughts or ideas about future work and research needs in this space. Thank you.
Thank you, Tanya. What a powerful presentation and pretty confronting data. I'm looking forward to our discussion in question time. My very excellent colleague from the Monash University Occupational Therapy Department, So-Sin Sim, has recently graduated Doctor of Occupational Therapy, and this is some really important research she's delivered. Thank you, So-Sin.
Thank you, Libby. Okay, so it's a great privilege, right, to be able to share and actually listen to so many different researchers and people who care about carers. So I'm especially excited to share in this very specific group of carers, mothers of children with disabilities. I think we've heard from previous speakers about, the different group of carers have got their little special, not always quite special, like their unique kind of challenges. And I think for this group of moms, right, just to set the context, if you're not familiar with this group of carers, is that they begin their caring journey, right, in a rather, I would call a traumatic manner. Because most of the times, when you go into motherhood, you are thinking, hey, I'm going to have a baby. Oh, everything's going to be great. Like a nice story is just about to emerge. And when moms have to deal with the fact that, their child is not neurotypical, or maybe somewhere along the way, an accident happens and they have to deal, the whole beautiful motherhood picture just crashes. And a lot of times, studies have been showing that moms do end up, or rather families end up having post-traumatic stress symptoms because of the disabilities that their children were diagnosed with. So it's in that context that I'll be sharing my research. So I'll start off by having an overview of, who are these mothers of children with disabilities and my work with specifically the Chinese mothers. And I'll share some findings and followed by the next steps that I think I'll be taking. Right, so literature has shown that, right, mothers of children with disabilities have got higher stress, poorer quality of life, poorer mental health. I think some of the earlier speakers also mentioned something to do with mental health, and I think it's very true that, carers do, the association between carers and, poorer mental health seems to be there consistently. And the literature also shows that mothers of children with disabilities tend to have reduced leisure time, poorer sleep, less self-care time, and they have got, pretty poor quality of sleep, so basically sleep disruptions, and this affects their daily activities. And specifically, one of our colleagues have done a study that shows that mothers with higher sleep disruptions have lower rates of participation in health promoting activities. And this just means like the normal day-to-day activities that you and I would do, like, going for exercise, socializing, having a cuppa, just having some quiet time, doing some spiritual things, mindfulness, reading a book and things like that. But some of these mothers, right, actually don't do them ever since they have their, their children with them. And the other thing about this group of moms, right, is that they tend to, those studies have shown that the dependency on mothers, right, of children with disabilities tend to go much, much, much longer than their peers. So for example, if I have a peer, right, who has got a child with disabilities, maybe I'm a mom with a teenager, I can start going shopping, I can start to spend some time on myself, but this other mother would be still looking after her teenage son and still having to spend lots of time on supervision of the child. So that's, generally found amongst mothers of children with disabilities. Now, my research, right, I've specifically focused on Chinese mothers of children with disabilities, starting with those that are living in Victoria, because that's where I am, and also because I'm a Chinese myself, ethnic Chinese. So my interest is really looking into these Chinese mothers' occupations. And as an OT, right, when we talk about occupations, we mean activities, the way people use time and their roles, and what do they think about themselves, their self-concepts. So what I was interested in was really finding out about what change process do these carers go through, like, specifically the Chinese mothers, like what's the impact of culture, and also what's the impact of if they happen to engage in meaningful activities, if they have a chance to, what impact does it make on their mental health, their lives, and what do they report about these experiences. So I'm just mindful that not everyone is like thinking like, hey, what's got this Chinese, the mothers got to do with, other mothers. But I think that there's a lot, because in Australia, I think that it's such a big group of culturally linguistic, cow population, that some of these findings can actually be translatable to particularly collectivist culture. So I'd like us to just keep in mind as I share my findings. So I had different phases of my research that include scoping, review, and qualitative interviews and quantitative survey. And what I want to emphasize on is that I had my qualitative interviews with the immigrant mothers who are living in Australia. And in my quantitative survey, I'm really taking a larger scope, like mothers who are living outside of Australia, so including Singapore and Taiwan, because that's where the Chinese population are quite high as well. So just to do some comparison and see what else is out there with the other moms living overseas. So very quickly to my findings. Oops, sorry. Right, I definitely found, right, that cultural influence and mom's belief system affects the way they choose their activities and the kind of role they play as a carer. And just a little bit of background, right, is that in the Chinese culture or a lot of collectivist culture, there's quite a huge stigma surrounding disability. So disability is often associated with that, bad karma, or you have done something bad in your previous lives, or you're indebted because you're evil, or you come from a terrible family life. So all these superstition and cultural aspects of things does bring a lot of additional burden to the moms already stressed and traumatized by the whole experience. And in addition, right, the Chinese culture is also, a lot of East Asian culture is affected by Confucianism, where moms or ladies or females are seen as the main person bringing up children who are very well behaved, very courteous, very polite, and very successful. So you can see how the combination of these things can really add on the complexity for Chinese mothers themselves. And there's a lot of blaming. I showed that finger there. A lot of blaming around moms having these children, and this is what they carry with them all the time. And I've heard colleagues shared with me about how some of the Chinese carers, right, they just keep their children at home. They do not want their kids to be in public, or they don't even try to access Carer Victoria even if it's there, because there's a lot of shame and guilt involved in being a mother like that. So I think that's something that we were, definitely is in the space in their minds as well. So moms really travel a lot just to, move, just to be comfortable recording themselves that my child has disability, and then I am a carer. So that's a journey itself. And definitely this role, right, affects mom's self-esteem, and they do not want to take their children out, hence very socially isolated. And sometimes it can even impact their family relationships, like, people blaming each other for the disability, husbands and wives, in-laws and moms, and etc. And the other thing about Chinese moms, because of Confucianism, right, the whole idea of the philosophy, right, moms actually put themselves out there, working very diligently, almost 24/7, and laying themselves out sacrificially to improve their children's status. And they always think about removing the disability as versus embracing the disability. So there's a big struggle in their minds. And for them, right, their everyday activities and roles are planned around their children's needs. And therefore, you will see a lot of Chinese mother visiting lots of therapists and multiple therapists and getting really anxious over their child's recovery that they're hoping for. And this is just a snapshot of my qualitative interview, where I found out that moms will go through a journey. Remember, I was interested in the change process. So all the moms that were immigrant mothers, right, they were immigrants, so which is really complicated itself already. And they're also carers, trying to master their roles and trying to redefine themselves as carers. And hey, who am I? I'm from China now. Am I a Chinese? Am I a Chinese Australian? Am I what? So they're trying to navigate these two things at the same time. And while they're going through this process, right, some of them actually had an encounter to have an opportunity for meaningful engagement. And this was found, right, in my qualitative interview. That's because in Australia, right, you have got a very good system of support. I think it's a very nice, good news for everyone, isn't it? The NDIS was helping and not helping at the same time, but generally very welcomed by the Chinese mothers because they don't have such a thing in their country. So because of this and because of all the platforms that's available in Australia, they actually walk out of this isolation a little bit better. And many moms did say that without the NDIS, I can't find time to do anything for myself. I can't even think, I'm just traumatized, and I'm just, there's no hope for me at all. So with the support systems, right, including their own families coming in, like extended family links out there, flying in to help them on and off, and a lot of faith communities coming in to help this group of mothers, they actually found some time for meaningful engagement. And just to zoom in a little bit on what happens when they actually have a chance for meaningful engagement. So when moms can actually find some space for themselves to do self-care, which is occupations for self, or they can find a volunteer role to be in, or helping other mothers, or actually doing their own hobbies. Like I've got moms who are interested in cooking and they're doing cooking websites, cooking for other people, or moms that do therapeutic soaps and they're sharing their special recipe with other moms and doing workshops for other moms and children with disabilities. It actually empowered them and it helps them, right, very therapeutically. And this could not have happened if they had not even stepped out of their perspectives. You know how I was saying about the trapped, mentality about shame and all that. They had a chance to revisit that, challenge that because of the inclusiveness in the environment. And also while they are learning how to be a carer, these two bits of the mastery and redefining themselves actually help them with the engagement. And this sort of goes.
Ask you if you could try and finish up now, just from
Yes.
unfortunately we are out of time. Thank you.
Yeah. Okay. Sorry. Should I just finish like next slide? Right. Yeah.
Yep,
So
go ahead.
sorry, time goes so fast. Yeah. So basically, right, the other part of my the quantitative study is basically the whole nutshell is that, right, mothers with found their lower well-being and higher mental health issues, right, and lower participation in health promoting occupations when they are moms in this space. And it's really important to provide support and reduce the amount of stigma that is associated with their caring role. That will really help them move on. And my next steps is really to do a co-design with Chinese mothers to develop a program with Chinese cultural specific, alterations for them. And also to look at how we can support moms and their big vision to support their children. Thank you. Sorry, I went off over time.
Thank you so
Thanks.
much, Sosin. Well, there's so much research in there, and we are going to have time for questions. We have one more presentation today. Our next presenter is Professor Anne-Marie Hill from the University of Western Australia, from the School of Allied Health there. Anne-Marie, if you'd be willing to start your sharing your screen, and we look forward to hearing from you, and then we'll have some time for questions from the group. Thank you.
And thanks, Libby. And can you see my screen?
Yes, I can. Thank you.
Thank you, everyone. And I've been just so heart-warmed to hear those presentations today, and it's been a marvellous session. So I'm going to briefly talk to you about two trials we're doing. One is a very large trial, which we're just finishing up collecting the data, and another one is a slightly smaller trial that we're halfway through. So I hope you'll find these reflections interesting for your further knowledge. So I'll be talking a little bit about the FETCH trial and the Stay Safe in Hospital project. And I'd like to start by just saying Kaya Wanju Noongar Budja and acknowledge the Whadjuk people of the Noongar Nation as traditional custodians of the land in Perth where I'm residing, and pay my respect to elders past and present and emerging of all nations, and especially of all the nations for other presenters, and pay my respects to any Aboriginal people who might hear this presentation. I'll first talk about the FETCH trial. You see by all the logos and acknowledgements that it's a very large NHMRC funded trial. So it's been progressing now for 2 years, and we're just coming to the other end. So we enrolled caregivers, and just to tell you what sort of caregivers we enrolled in our trial, it was any family member or were a non-family member who provided support for at least an hour on a regular basis, and they had to be over the age of 18 years, not necessarily living with the patient. But for us, we were very interested in the position of people caring for older people. And so the patient that they cared for had to be 70 years old. So we were looking to recruit people where the person over 70 years old had been to hospital. And there may be different needs, of course, once a person has been sick and been in hospital. So our hypothesis was that if the caregiver was well prepared, then they might be able to sustain their care in a better way. And that would also perhaps give the patient better care as well. So we evaluated in our trial, or are going to evaluate, the caregiver's health-related quality of life and preparedness to care, and we'll also evaluate how the patients are going. So where are we up to with our trial? We have been delivering the Fetch program. So what is the Fetch program? It's a telephone service, which is why I've been very interested to hear the previous presentations, including from Carers Victoria. What happens is anyone we've enrolled in our trial, that carer, has received telephone support by an experienced nurse. There's one of our nurses there. And they will support the caregiver of the older person who's returning home from hospital. And they try to build the caregiver's capacity to manage caregiving successfully and empower the caregiver to sustain their caregiving role for as long as they desire. In this trial, we focus on the caregiver's needs, and again, that theory being that if the caregiver is feeling well prepared and able to feel emotionally supported, then that is going to help the caree or the care as well. So people receive 6 telephone calls. The first one was very soon after they went home from hospital, and then others followed along in the couple of months after that. So where are we up to with our trial? We have finished recruiting. So we have 566 carers along with the person they care for, so dyads or pairs. And of those caregivers, about 40% are a daughter and 25% a wife, 17 a son, and 11 a husband. And so half the people in our trial have been receiving the Fetch program, and the other half have been receiving the usual care they would receive if they went to hospital and had discharge programs, etc. So we're just following along with that at the moment. So we have finished the intervention and we're on to the final follow-up data. So what are just some early reflections? We don't have the results to present to you today because they'll be a little bit further down the track. But what our nurses have told us so far is that it's been a very positive, yet challenging, yet rewarding experience for them. And here's a nurse reflection from one of our nurses that says, I was pleased that the carer was appreciative of the links and resources emailed and posted from the previous call. I felt like I have been able to provide practical, tangible support as a Fetch nurse. And it's interesting that the nurses have commented on what other people have commented on our speakers today, that although there is help there, our participants have been appreciative of help to navigate what's there. And you can just see a little bit of carer reflections, and I won't try to tell you lots today. But one of the carers said, it was absolutely one of the worst times of my life, actually. That's the person they cared for being in hospital and being ill. And I think your program carried me, and I really mean that from the bottom of my heart. So people appreciated, I think the nurses found people appreciated the emotional support as well as the physical help, physical resources. And here's another person, and these are not unusual comments. Most, if not nearly all of our people were very, very positive about what they'd received. So this person said, I do think the program helped me a lot. I feel more confident in that I know there's help out there, which I wasn't aware of before. I didn't know how to access it. So I do feel it's made a huge difference in my life. So people felt that the Fetch nurse, when they spoke to them on the phone, were able to help them navigate and learn, and also emotionally feel supported in their role as a caregiver. And we know our Fetch nurses are marvellous nurses and gave people tremendous support. So that's been really good. And I'll just spend a couple of minutes telling you about the other trial, because we're also interested in what people are experiencing within the hospital. So we have asked carers and other older people about entering hospital, and we're very interested in people's mobility and safety. We've asked them what they've found when their loved one has gone to hospital and they've been there as the caregiver. So we've just been trying to hear people's experiences and really find out where we think we're at. Because somewhat, although we'd like to think we've advanced a lot, we still found some somewhat disturbing stories of people's loved ones. And so this was a daughter who felt that their mother was somewhat ignored in hospital. And you can see this comment, they will put her in a bed and put the cot sides up, and then they'd leave her in a bed with the cot sides up without a call bell or anything. That feeling the carer had there of the people were not treating the person that they cared for with the attention and the understanding that they felt was needed. So that, those were some of the comments we received. And we also had the comment, it's a very interesting one, isn't it? You get put into that older category by a person who's an older carer. And this person was talking about they felt because they were older that was the reason that they were, their needs perhaps was being listened to. And another carer commented on the lack of understanding about the person they care for being independent, and saying, if people are independent, they don't like to necessarily ask the nurse for help. And you can just see this other person said, about their loved one, just some of the ways they spoke to her, they just treated her like she left her brain at the door. And yet, in a past life, this lady had been a registered nurse. So again, that feeling of a cognitive dissonance about the way the person they cared for was being treated and how could they get through. So those are just some snippets of what we've been doing. And much as we've been trying to look at how we can help people after discharge, we're very keen to look at how the carer can be empowered inside the hospital setting as well. And I'd like to just particularly mention our consumer advocate, Howard Lance, on our trials, who's been providing us with tremendous consumer support from Carers WA, so that we really make sure we're bringing the carer perspective into everything we do. So thanks, everyone. And of course, I will take some questions.
Thank you, Anne-Marie. What an interesting and innovative approach to service delivery. I'm really pleased to say we've got about 15 minutes now for questions and discussion, and we already have some questions that I'd like to put forward, but I do welcome our audience now to put questions into the Q&A section of the Zoom webinar, to use the chat to raise any other questions that you have. I'm going to invite all of our speakers to turn on their videos, and we'll start off with some of the questions and discussion now. Look, one of my questions first is what came through each of your presentations was really the challenge of identifying carers, identifying young carers, identifying carers as mothers of children with disabilities, identifying carers through innovative service models like Aslan and Anne-Marie have spoken about. Tanya, just particular to that younger carer group, how do we work to identify people to engage and support them, given those mental health impacts that you've mapped out so clearly in your work?
Such a tricky question, Libby. And, I think one of the big issues, and the care organisations will be able to speak to this probably better than me, is that so many times, and this has come through in talking to some of the young carers that have been involved in our work, they're sort of picked up in very different systems. So it may be that they're picked up in the health system when they're in hospital, or when they're visiting a parent, for instance, in hospital, and it comes to light that they are a carer. Or it may be in the education system, or there are all these different systems that operate in a very siloed way. And so I guess one sort of avenue would be to sort of be better linking some of these different systems. But really, I think I would love to know how we can really start to address this. So some of the other speakers may have some good ideas too.
Thanks, Tanya. I'm going to welcome Tamara just to really give her perspectives from Carer Victoria. Just while you're unmuting, Tamara, it's been really interesting to share the Young Carers bursary through our student network and start to really get contacted by individual students in our School of Primary and Allied Healthcare, identifying as young carers for the first time to access that bursary. And that's really been a valuable contribution. Do you have other comments on other ways we can support people to identify where they're comfortable to do so?
Yeah, thanks, Libby. I think it's a really important point because I do think we actually do have to find a way to help carers identify. It's too hard for them to get way down the track to identify. Going to the young person, I think we have to look at existing systems. So we have to identify the target cohort and say, well, where are they? And obviously, naturally, young people are in school. I know here in Victoria, we have a mental health practitioner service that's now been run out to primary schools as well as secondary schools. So that would be immediately the thought in my head of working more closely with those mental health practitioners so they can identify carers and they can help the young people identify and then link them to those services like the bursary. Because you see that come through and a notice from the school, but you don't really understand what that is. And kids don't necessarily go, oh, well, that might be me. They do actually need a teacher or a mental health practitioner to say, hey, this is actually you, and help them, access that service.
Great point, Tamara. And again, I was thinking when I was listening to Tanya about our curriculum, training the future healthcare workforce, that really they need to understand what is the definition of a carer. And I love the way many of you brought that into your discussion. So, Sin, as an educator of occupational therapists of the future and through your PhD research, any other reflections on identifying carers, particularly the group that you identified that really might have a whole cultural overlay of why they would not want to have that role identified?
Well, I think that what I found from my participants, I mean, obviously, when I was looking for participants, I had difficulties because they are not identifying themselves. So what I think happens is that the moms, right, who sort of self-connect and they kind of group together where they're trying to find a space where they're not stigmatized. So all these Chinese moms, they will just gather themselves together. And then one or two of them might be linked to maybe Carer Victoria, or they go to a workshop. Remember, the moms are very into learning about how to get their kids better. So that's where I think the catchment area is. So, going to parent workshops, going to special schools, or even connecting with the learning support services in schools, because that's where their kids will land in, or therapy services is where you could find those moms. And I think taking a family-centered approach is definitely important. Even the GPs, for example, if they know that the family has got a child with special needs, and then, whether it's a Chinese or whatever other moms, right, that the GP or the first point of contact actually sees the family members as a part of this whole gamut of care, and I think that's where the starting point might be.
Thank you. I'd like to turn to Anne-Marie and Aslan. You've described today two really innovative models of service delivery. Anne-Marie, can we talk a bit about how you developed the Fetch program? What made you think about the idea of that phone-based support of nurses? Could you just talk a little bit about that? And then I'll hear from Aslan about the Carers Clinic.
Yeah, thanks, Libby. The Fetch trial started as a pilot some years ago, and when it seemed to be positive, then it was set up by a group of nursing staff and researchers at Charles Gardner Hospital. And I came on board when the larger trial was being planned. And I think it stemmed from the noticing by clinical researchers and clinicians that when people went home from hospital, the carer themselves began to really experience stress and back through ED because there hadn't been enough discharge planning. And we just thought, well, we need people to receive support so that when the person goes home from hospital and there might be new needs and they might be functionally declined, there's some support for them. And interestingly, when COVID came along, some people said to us, oh, you should move online to Zoom or to Microsoft Teams. So they're kind of like today. But we found the telephone was really appreciated by people as so simple. It didn't need too much technology. You just picked up the phone, your mobile phone could be anywhere. And so mostly our carers that have been in the trial have been very positive about how the telephone in a way is better than, say, appointments or needing to go back into clinics. So that's, I think, really interesting.
Really interesting, and I think something for us to really consider closely. It came up in the New South Wales session earlier, digital literacy, and Tamara touched on it further. There's this expectation that everyone wants to connect digitally. The phone is a simple tool. It can be a really accessible tool for people.
Yes.
As the new carers clinic, how did that concept come about? How has co-design been brought into that?
Following our interviews that we did do, and interesting that you should say phone, because a lot of our carers did actually opt to have phone interviews rather than and it was just purely for convenience. And I think partly that anonymity as well, that they could just connect with someone but not have to, repeat their story, and maybe, some privacy to that.
Okay, some other questions for the group. I was particularly interested to hear, Tamara, some of the considerations and how the NDIS has come through this afternoon's session, both through the earlier session, through your first presentation about system navigation. We've seen great impacts of the scheme, but we're also hearing some of the pressures it's making. Have you got any sort of key suggestions for the sector, both in research and practice, around how we support carers within the NDIS?
Oh, I wish I had the magic bullet. I truly do. It's so difficult. I mean, it brings so much benefit. When it works, it's amazing. I think that what sits behind it, though, is just so much administration. And I hope that some of the things that Bill Shorten's trying to do will reduce some of that. It's fantastic that some participants now don't need to have annual plan reviews. But the flip side of that is their circumstances change. So you've got to have a mechanism for that to work really quickly. I think that point would be a point of focus for me for people whose circumstances changed, for that process to be quick and simple and to get urgent care response. And then perhaps maybe down the track, some of the other, improving the system and the flow. But I think if we make it easier for the person with the disability, that is going to make it easier for the carer. Because that service system does look to the carer a lot to speak on behalf of the person with a disability, which is something we battle with in allowing the person with the disability to speak for themselves. So there's all those tensions, but I would say making urgent care more flexible and responsive would be a priority for the system.
Thanks. I'm going to ask some others to respond to that pretty hard question. But before I do, Tamara, I was interested to hear a representative from the Department of Health and Aged Care recently talking about their new work to set up my aged care officers in Centrelink offices so that there was more support of information in person. Do you have any feedback from Carers Vic about what the experiences of carers around that sort of model? Again, it requires people to travel to the office to get that information, but any reflections at all on that?
Not specifically from our carers, but I would say anywhere where co-locating services is a win. And I did hear a story even yesterday from a carer who was trying to navigate something to do with vaccines and went to Centrelink and they were in the wrong place and it wasn't the right service, but Centrelink offers helped them. So I think when you've got services co-located, also they learn from each other. So I think it's a fabulous model. And I think some people actually do just want to see someone face to face. It is entirely so frustrating to spend so much time on hold and you never quite know where they're going to pick up. So going face to face is an option. And what last point I'd make is there needs to be options. You need to be able to do face-to-face, phone call, Zoom, send an email, live chat. It's fantastic, the digital options we have, but we need a range of things because people have different circumstances and different needs.
Yeah, Tamara, if I could just come in quickly, what our nurses reported was that it was helpful for them to, in some instances, they gave the carer some language and some questions to ask. So because, they'd suggest you ring people and then they'd say, what I suggest you do is ask this, this and this. So it's like almost the services, as you say, have their own language and you almost need an interpreter, even though the people are speaking English. You need someone who's given you some of the language about what it is that you should ask them.
And I loved that point made earlier about the different languages across systems. And a lot of my early work in the NDIS was teaching NDIS participants and their families what language to use to get the best planning outcome. And it was literally a language other than English. And so, you know, when I think about Sin's work and working with culturally and linguistically diverse communities, you know, you had to learn a whole new language to operate in the NDIS. And so, Anne-Marie, I love that point that you're making. Tanya, I was thinking about the systems interfaces. We've talked about system wrangling today a lot, and Tamara really opened that whole dialogue up in her first slide, which I've put out on Twitter because it really struck me. You've really shown that it is very likely that younger carers will end up in a mental health system. Is that fair to say, firstly? Is that fair to say? And then if it is, how do we support people entering that system, you know, with that identification as a young carer?
Yeah, thanks, Libby. I probably can't say from the research that we've done that they are more like that they will end up in the kind of mental health system in some way. Probably just that it appears that they have. It appears that they may be more likely to on the basis of these associations that we're seeing at this sort of age. And sorry, I've forgotten your latter point after how do we...
So thinking about system interfaces, thinking about, you know, wrangling that system of, you know, I have a family member that needs caring and they might be operating in certain systems. I am a young person, so I'm in the education system. I may, as you said, end up in a mental health system. How do we make sure those systems speak to each other? How do we get that communication?
Really, really tricky. I don't know whether it's going to take some sort of complex systems approach, some sort of way of getting these sort of siloed systems to better integrate. I would love to know, and I guess someone else may have the some insights there. But I think I don't have the answer, but we clearly do need to be able to get these systems to better integrate and better respond to the needs that are going to be occurring across these different systems.
Thanks, Tanya. And we've only got about a minute left. I might just throw that very hard question out. Is there anyone else have comments on that, getting systems to talk to best support our young and adult carers and older adult carers? Any immediate thoughts on any possibilities in that space? While I ask that, I guess I would say I think research and evidence is what talks well to government and policy. So thank you all for the research you're doing, for the advocacy work you're doing through your organisations, and particularly to Carers Victoria and Carers New South Wales and our other carer organisations, Carer Western Australia, Anne-Marie was highlighting. These are vital entities, and evidence is going to inform policy. Okay, well, it's 4:30 on the dot, so we've done well with our time. We now have the opportunity to say thank you to our amazing set of speakers, also to the team that put together the Carer Knowledge Exchange today. I've learnt so much across the two sessions. Otherwise, I'd like to thank our speakers today, Tamara, Tanya, Aslan, Anne-Marie and Sin. It's been a wonderful session and we've all learnt so much from you. Thank you very much.